Thank you. Well, welcome everyone. So glad to see so many of you here today as people continue to gather. We are expecting a very large group, so glad to have everyone here. Welcome to the New Jersey Healthcare Quality Institute's Maternity Action Plan work session. We know that many of you have been to these work sessions before and have worked with us over the years, but I'm very glad to welcome you today. My name is Kate Shamzad, and I work as the Director of Policy with the Quality Institute. Before we dive into our very ambitious and packed agenda, I wanted to thank you all for your dedication to improving birth equity in New Jersey. I know many of you have been attending many events over the last week as we celebrate Maternal Health Awareness Day, which has continued through the rest of the month. And so we're glad to have you all here today. I also want to welcome many out-of-state attendees who have been part of our map work from across the nation. We have over 200 individuals signed up to participate today. Excuse me, during today's work session, we'll be giving you a brief overview of the Maternity Action Plan to start, and then talking about our newest report that the Quality Institute released last week. Then we'll transition to hearing from a panel of subject matter experts working to bridge gaps in care across the state. And then finally, we'll come back together for a group discussion and to close out the afternoon. There'll be opportunity throughout for you to ask questions and for us to dialogue at the end. So if it feels like you're listening a lot, I know you are, and we hope that you'll have a chance to participate in conversation as we go through the next 2 hours. Before we go into the content, I want to go over some housekeeping to ensure that we have a smooth session. Please note that we are recording this meeting and it'll be available on our website, and the link will be made available to everyone who's participating today. We've enabled also Zoom's AI companion, which is a virtual assistant that takes a transcript and a summary for us. We'll be sharing that after the meeting as well. Kindly keep your microphones muted.
Changes, I'm here.
You muted yourself, Kate.
Oh, thank you. Look, that was a good example of how to mute yourself. Please keep your microphones muted to minimize background noises. We do have a lot of people on the meeting. This will contribute to a more focused and productive environment for us. And as we navigate through the agenda, please feel free to step away if you need to. We know this is a long chunk of time to be sitting in front of your computers. We don't have any built-in breaks, but we encourage you to do what you need to feel comfortable. You're welcome to leave any comments or questions in the general chat, and Vanessa Gibbs, our communications manager, will be monitoring that throughout. She's also available to help troubleshoot technology issues if you'd like. She is managing a lot of things, however, and running our slides. So if it takes a moment for any one of us to get back to you, that's why. Next slide, please. Our agenda for the day, just like I said, we do have an ambitious day ahead of us. And so you'll see here all of the different components of our project and our work together today. Next slide. The work sessions that we're bringing you today and that we've brought you throughout directly link back to our Maternity Action Plan, or the MAP. In partnership with many of you and individuals across New Jersey, we created and released the MAP, or the Maternity Action Plan, in July of 2022. And since then, the MAP has shown to be a holistic approach to making New Jersey the safest place in the nation to give birth and raise a child. Within the MAP and within these work sessions, we've focused on 4 critical pathways: building the maternal workforce, collecting and using data, reforming payment systems, and improving community-based social supports. We'll touch on many of these today. Next slide. In 2023, as a next step for our MAP work, we've launched MAP to Action. Like today's session, we've hosted virtual work sessions for each MAP section, featuring subject matter experts from various sectors across the state and country, including healthcare, law, community organizations, and government. For recordings and resources and to see any of our past MAP work sessions, please visit our website or use the QR code on the screen to get to that section of our website. We've also held 2 in-person convenings with over 100 individuals attending either, and our most recent in September featured conversations with many of you, fostering networking and collaboration. Our planning for the first convening was shaped by conversations from these virtual work sessions, as was our second. And with that, we created the 6 maternal infant health values that we hold true in all of our MAP work sessions. These values are central into our discussions and continue to guide the Maternity Action Plan work. In addition to today, we'll also be hosting 2 virtual work sessions coming up, and at the end of our presentations this afternoon, Linda Schwimmer will be sharing more about our next session in April. We hope that we can continue this work with you with the optimal goal of optimizing maternal health care in New Jersey. So with that, we're going to transition to our first section of our presentations today, where I'll be sharing our new report with you. Vanessa, next slide, please. We're going to be highlighting a recently released report that the Quality Institute put out last week called Navigating the Obstacles, the Complex Journey of Perinatal Care in New Jersey. We shared a link to this report, and it is available on our website, as well as a 2-page brief, which will give you an overview of the report, but we wanted to be able to share it in more detail today. The report examines coverage gaps and disparities across our state's regulated and state-funded insurance programs, highlighting their impact on maternal and infant health outcomes and exploring barriers pregnant individuals face when accessing equitable, high-quality care. Next slide, please. Through patient journeys and data analysis, our report illustrates how coverage of behavioral health, postpartum care, and social supports can create challenges for families. It offers actionable policy recommendations to promote equity, expand access, and improve care for all New Jersey families. Before we get started into the content of the report, I just want to say how grateful we are for the funders of this work, the Community Health Acceleration Project, or CHAP, the New Jersey Birth Equity Funders Alliance, or NJBEFA, and the Community Foundation of New Jersey. They all supported our research and making this report possible. And I know that many of them are joining us today. Next slide, please. The goal of this project served to understand access to high-quality perinatal care for everyone in the state, which is critical to improving maternal and infant health outcomes. Today, we'll explore the 3 key objectives of this report. Assessing existing coverage policies for perinatal care, identifying gaps and disparities across state-regulated and publicly funded healthcare coverage, and then lastly, recommending policy improvements to enhance access and equity. As we discuss gaps in care today and potential policy recommendations, that will lead us directly into our panel, where we have a number of experts here to share ways that they are bridging gaps and ensuring that people have access to care. Next slide, please. In New Jersey, the scope of perinatal care coverage varies significantly between state-regulated insurance and public health care coverage. And when we talk about public health care coverage, we're really referring to 2 programs, Medicaid and the Supplemental Prenatal Care Program, 2 of which we'll focus on today. Key gaps exist in drug benefits, behavioral health services, dental care, and social supports, such as transportation. For example, while New Jersey Family Care offers comprehensive coverage, programs like the New Jersey Supplemental Prenatal and Contraceptive Program, or SPCP, still a mouthful, provide only limited benefits with critical gaps in care. This report also highlights the coverage of the major state-regulated health markets, including the individual market, small and large employer groups, and the State Health Benefits Program. Next slide. While we won't have time to talk about all of those different health programs today, I hope that you all take a dive into this report and understand exactly what's covered under each one of these insurance programs. But for today, we'll be focusing on 2 pathways, Medicaid and the Supplemental Prenatal Care Program. First, let's take a closer look at the pathways for enrolling in New Jersey Family Care, which is New Jersey's Medicaid program. In the state, approximately 1/3 of pregnancies and deliveries are covered under Medicaid. There are a number of enrollment pathways with applications accessible in a variety of ways so that individuals can apply in a way that they're most comfortable with. The easiest pathway is certainly online applications, but people can also apply for NJ Family Care via phone, mail, or in person with the county welfare agencies. Because pregnancy is a critical period of time to get health care right away, pregnant individuals can also benefit from a program called presumptive eligibility, which allows for immediate temporary coverage paid through the state's Medicaid fee-for-service program. This allows them to get access to prenatal care while their application is being processed, ensuring timely access to care, particularly when the need is urgent during the first trimester. However, it's essential that folks apply for a full Medicaid application because presumptive eligibility only lasts for a short time frame and full enrollment is needed, especially to enroll in a Medicaid managed care organization. Next slide, please. For each of the insurance types explored within the report, we present a chart that looks just like this, so you can compare across all of the insurance products what's covered. This slide represents the NJ Family Care Medicaid Managed Care Organization coverage. NJ Family Care covers pregnant women who live in New Jersey who are either U.S. citizens or lawfully present immigrants and have a total family income at or below 205% of the poverty level. It's important to know that coverage extends both for the mother and child for 12 months after delivery or the end of pregnancy, regardless of income changes. And this offers extended care, particularly during the postpartum period. Once enrolled, members receive comprehensive prenatal care, which includes medical services for both the individual and their newborn. It includes midwifery care, childbirth education, lactation support, and breastfeeding equipment. The benefits are extensive under NJ Family Care, particularly when received through the managed care organizations, and they address key areas like ensuring that individuals have drug benefits, access to behavioral health, social support like transportation and food support when needed, birth facility benefits, including the ability to birth at a birthing center if Medicaid is in contract with them. It also includes extensive reproductive health, including long-acting reversible contraception or LARCs and abortion care, as well as postpartum non-maternity care. So if there's a need to see another type of provider, full Medicaid coverage is again provided for that 12 months post-pregnancy. In addition, Medicaid in New Jersey covers dental services. This is not the case in every state, but New Jersey Medicaid does cover dental services for adults, and it's important to call that out. Next slide, please. In contrast to NJ Family Care, let's take a look a little bit closer at the New Jersey Supplemental Prenatal and Contraceptive Program, or SPCP. This fully funded state program is designed to offer limited benefits focused on outpatient prenatal and family planning services for individuals who don't qualify for broader Medicaid coverage because of their immigration status. Of note, we tend to use gender-neutral language when we speak about pregnancy and perinatal care. However, the SPCP program specifically uses women in reference to the type of coverage that's provided. So when I talk about SPCP, you'll hear me say women versus the pregnant individual. This program is designed for women ages 19 to 64 who are New Jersey residents with incomes up to 205% of the federal poverty level, exactly the same as those who are eligible for Medicaid. However, this is for women who are ineligible due to their immigration status. Of note, if someone is under 19 and pregnant, they can be covered under a program called Cover All Kids, which is fully state funded, but offers the comprehensive benefits of NJ Family Care. Enrollment in SPCP is available through a provider's office, clinic, or hospital, anywhere that you can be enrolled in presumptive eligibility, and that office will complete the application with the woman. It allows for temporary coverage while eligibility is formally processed, ensuring access to prenatal care immediately. The SPCP is temporary, however, and ends after birth for all prenatal and postpartum care, except for contraceptive care. Temporary coverage remains in place while full eligibility is determined, but there are critical pathways to care that are not covered under this benefit. Next slide, please. As I said, the program focuses on outpatient prenatal and family planning services, including contraceptives, pregnancy tests, family planning counseling, and lab tests, and there are significant exclusions. There are no drug benefits, no behavioral health benefits, and no social supports offered. It also doesn't cover the birth facility, which is covered under an adjacent Medicaid program called Medical Emergency Payment. It also includes no postpartum care via the obstetrician and no dental care, creating significant gaps in critical follow-up services. SPCP's limited scope leaves significant gaps in care for the underserved population, particularly those who require more comprehensive services across their pregnancy and postpartum period. Addressing these limitations is essential, and we'll be providing some policy recommendations in just a few minutes. Next slide, please. If you thought you were just going to look at tables and charts for the majority of this presentation, I'm excited to switch gears a little bit. One thing that's unique about the report that we created and put out last week is that we have found that it's much easier to understand these gaps in care and across our insurance markets when we look at specific patient scenarios. So these journeys that I'll be sharing with you, going over 3 different insurance market products, are illustrative. These are not real individuals, but based on our research and interviews with care providers, we were able to create 3 illustrations of what it might be like to access care across the perinatal continuum for 3 different patients. We want to introduce you today to Anna, Sarah, and Amanda, each navigating the perinatal care system with different types of insurance. First, let's learn about Anna. Anna is enrolled in NJ Family Care and began her pregnancy excited, but a little bit anxious. She experienced delays in accessing her first in-person prenatal appointment because of high demand at her clinic office and limited clinic capacity. So she had her first appointment via telephone triage. When she had her appointment and was booked to a clinic, she was told she would be seeing providers at different clinic locations. This made transportation a challenge, as she would require Medicaid transportation services to get her to each one of these multiple clinic locations. Anna wanted the support of a doula, but struggled to find one to be reimbursed through NJ Family Care. Many of the doulas she contacted were either ineligible for reimbursement by NJ Family Care due to the restrictive credentialing policies, or unable to afford providing services at Medicaid's low rates offered for reimbursement. Later in her pregnancy, Anna was diagnosed with severe gestational diabetes, but delays in obtaining medical approvals for necessary medications from her managed care organization prolonged the time to treatment. At delivery, Anna requested immediate postpartum contraception in the form of a LARC placement, but her hospital did not stock IUDs for New Jersey family care patients because of the complexities for stocking and reimbursement. Anna's story demonstrates persistent barriers in Medicaid services, from delayed care to limited access to postpartum and doula support based on reimbursement. Next, let's meet Sarah. Sarah began her perinatal care journey at a federally qualified health center after learning she might qualify for the New Jersey Supplemental Prenatal and Contraceptive Program. As a non-U.S. resident, Sarah was ineligible for broader Medicaid coverage, leaving her reliant on SPCP's limited benefits. Her journey started with a phone take at the FQHC, where a clinic specialist completed her presumptive eligibility application for SPCP. However, delays in processing meant it took weeks for Sarah to receive her Medicaid ID, which was required to schedule her first trimester ultrasound, which wasn't offered at the clinic, and she needed to go to the hospital to receive. This delay created stress and limited her access to critical early prenatal care. Throughout her pregnancy, Sarah struggled with transportation challenges. As SPCP does not cover transportation support, Sarah had to rely on family members for rides to the clinic, where she needed specialized care for her pregnancy. This dependency often delayed appointments and added strain to her already complex care process. During her pregnancy, Sarah was diagnosed with preeclampsia, a condition requiring medication to manage her blood pressure. Unfortunately, SPCP does not cover prescription drugs, forcing Sarah to pay for the medication out of pocket, a significant financial barrier for her. Despite her efforts to manage her condition, the lack of comprehensive coverage heightened her stress. When Sarah gave birth at 39 weeks, the delivery costs were paid for out of the Medical Emergency Payment Program, which covers in-hospital expenses. Sarah had previously expressed interest in immediately getting a Nexplanon contraceptive implant before leaving the hospital, but because the SPCP program only covers care outpatient, she was unable to get the Nexplanon implanted during her time in the hospital. She had to return to the FQHC for family planning services after being discharged, and family planning and contraceptive care is the only postpartum care that's offered under this plan. She wasn't able to have a postpartum appointment. After delivery, her challenges continued. Her SPCP coverage ended with her pregnancy, leaving her without postpartum benefits, including lactation support or mental health services. When a pediatrician noticed signs of postpartum depression, Sarah was referred to a nonprofit organization that provided mental health care with a charity basis because there was no behavioral health coverage. This fragmented system left Sarah to navigate complex care on her own. Her baby, however, did qualify for New Jersey Family Care after birth, but Sarah remained having high out-of-pocket postpartum expenses for her own care. Lastly, let's meet Amanda. Next slide, please. Amanda is a New Jersey resident who purchased commercial insurance through the Get Covered NJ marketplace. She faced a challenging and stressful perinatal journey due to financial barriers based on her coverage. Although she has subsidies which help lower her monthly premiums, her high deductible plan has left her worried about out-of-pocket expenses that cover essential prenatal and delivery care. At her first prenatal appointment, Amanda's provider did not conduct a perinatal risk assessment, a tool that is required for all Medicaid patients to identify social, financial, and behavioral needs. This meant that her anxiety about financial and emotional demands of pregnancy went unnoticed and unaddressed. Amanda hoped to work with a doula to support pregnancy and childbirth, but her commercial insurance did not cover doula services. And after contacting a few local doulas, she realized the cost for paying out of pocket was out of her budget, leaving without additional guidance and advocacy that she had hoped for. In her second trimester, Amanda experienced severe anxiety, leading her to an emergency room visit. And while the ER provided immediate care, the high copay left her financially strained. She was referred to a community mental health service for managing her anxiety, but the ongoing costs of therapy were prohibitively expensive under her insurance plan. As a result, she had to forego mental health care, compounding her stress and worry. As she prepared for delivery, her anxiety intensified about the anticipated costs of childbirth under her high deductible plan. She reached out to the hospital to discuss payment and financial assistance options. And while they offered her resources and supports, the structural limitations of her plan meant she was still faced with high out-of-pocket expenses. Despite all of these challenges, her plan was comprehensive, and she was able to access timely prenatal checkups, necessary screening, and childbirth education classes, which were all covered under her plan. After delivery, Amanda added her baby to her insurance as a qualifying life-changing event, and ensuring coverage for both her and her newborn would continue. However, the financial and emotional toll of her journey underscores the need for more comprehensive insurance benefits, even under our commercial health market. Next slide, please. So as we think about the challenges these three individuals faced across their perinatal care journey, we have a number of policy recommendations that we will share with you. First of all, we would like to see a number of changes, or we have a number of key policy changes that would improve the supplemental prenatal and contraceptive program, including providing prescription drug benefits for pregnancy-related conditions like the one I described with preeclampsia. Offering integrated behavioral health services, we know that mental health and behavioral health are a significant challenge across the perinatal period, and being able to address them can significantly reduce maternal morbidity and mortality. Covering them under the SPCP is essential. We also know that dental coverage is essential during this time period as well and is critical to the health of both the mother and the infant. And so we would encourage the SPCP to include dental coverage as well. Also important would be social benefits. So that would include transportation, which is very difficult, as well as other housing and food-related needs, which often come hand in hand with the need to be on a Medicaid or the supplemental prenatal care program. And finally, postpartum care is essential. We think that the SPCP program is missing this critical element of care, and there really needs to be medical care provided, particularly for postpartum care immediately following the birth. Together, these recommendations represent a roadmap to making the SPCP more equitable and effective, addressing the full spectrum of care required for healthy pregnancies, better outcomes for families. Next slide, please. In addition to improvements that would help the SPCP specifically, there are also added policy recommendations that we have for all of the state coverage, including commercial plans. First and foremost, increasing access to doula services through standardized coverage, funding, and training is essential. Doulas do not help just individuals who are on Medicaid, but can be supportive and supportive advocates for anyone who's having a baby in New Jersey. And we would recommend consistent coverage across all state-regulated insurance products. Additionally, there's need for enhanced dental care awareness. Education and outreach programs are essential to raise awareness among perinatal care providers and pregnant individuals about the importance of oral health during pregnancy. And poor oral health can affect maternal and infant outcomes. So dental care is key, and there needs to be more education and outreach, as well as access for dental care during this time period. Likewise, we believe there needs to be standard access and coverage for behavioral health. That's been a component of all of the work that we've done in terms of recommending integrated behavioral health. And today we're going to be able to talk a little bit more about solutions for that. Behavioral health services should be consistently covered across all state-regulated insurance markets, and they should be comprehensive from prenatal through postpartum care. This can be done through integrated care models that promote combining medical, behavioral, and social services under one roof or in one office. There needs to be more attention paid to integrated facility license and payment reform that would allow this integrated care really to become a reality. There also is a need to focus on improved postpartum coverage, thinking about the complexities of postpartum care, which includes not just your postpartum visit with an obstetrician, but chronic disease management, mental health support, and preventative screenings that can make the perinatal period safer and healthier as folks either plan to have another baby or move on with their lives. Next slide, please. Closing gaps in perinatal care coverage are essential, and we encourage all of you to take a look at this report and look at the information across all of the insurance markets. In New Jersey, with targeted policy changes like the ones we've outlined today, the state can ensure that all pregnant individuals have access to comprehensive care and support that they need for healthy pregnancies and across the perinatal period. And we encourage you to take a closer look at this report and how it fits in with your work. I'm going to turn things over now to Linda Schwimmer, who will be able to lead us through a brief question and answer block.
Thank you. Thank you, Kate, so much for that comprehensive overview of all of the MAP work as well as the patient journey that we released. And I appreciate that a couple people have already started putting some comments in the chat about ways that they're filling the gaps. I know that as you're listening to a lot of these policy recommendations, many of you who work directly in healthcare and or social services and are working to support people across New Jersey are faced with the threat of shutdowns and freezes and cuts, and are experiencing a level of uncertainty, as we all are, as to really what's going to happen next with a lot of these programs. And we are not oblivious to this, but I would say that through the MAP and all of our work, we're really working on the system that we want to see, the system that we're working towards together, that we know is necessary to improve perinatal care and birth outcomes for everyone. So in the context of thinking about this in an aspirational vein, and what I would love to put to all of you is, what questions do you have for Kate about the report and some of those gaps you're seeing? And then also, if you heard of a gap that Kate raised and you're aware of existing approaches to close those gaps, we'd love to hear from you as well. And at this time, we have a few minutes, so we can use the raised hand function, or if you want to share that through the chat, that is fine as well. So I'm not, is any, Kate or Vanessa, I'm not sure if I'm seeing anyone's raised hands at this point.
I think we've just thrown too much information at you all at once. I'm not seeing any raised hands, but we do have other opportunities throughout the morning, or I guess the afternoon, for discussion. I do see one question in the chat. Should we focus on legislative changes? A lot of different policy levers that can be used when thinking about insurance coverage. Certainly legislation is one of those policy levers. There's also an opportunity through state rules and regulations to make changes to insurance coverage without legislation. And so there are different pathways that could help address a number of these policy recommendations. Like Linda said, it's a bit of a volatile time in healthcare, as you all know, in regard to how federal policies impact state policies. And so there's definitely definitely different levers that should be explored.
I will just point out for those who didn't see that there are a couple comments in the chat that I certainly want to draw attention to that Kate had mentioned for the supplemental coverage program that medication is not included. And Karen Barnett pointed out that many of the FQHCs, as well as she didn't mention, but hospitals, some hospital systems, essential hospitals, do have 340B program pharmacy services. So those are services where people can receive drugs. I don't know, Karen, or if anyone on the call wants to share a little bit more detail of that resource. And then I know that there are, including children's, I know that there are some doula programs that are free of cost for those who are not Medicaid eligible. However, I believe that most of those at this point are funded by foundations. And so, one of the things that we're thinking about in this report and in our recommendations generally is looking at ways where we can be making sustainable systemic change. As much as we love the support of foundations, it's really important as we're looking at critical needs to see how we can have those built in a systemic way so that programs that are evidence-based and can don't come and go based on the availability of philanthropic funding. Kate, I don't know if you want to mention anything about lactation services and how they're part of coverage and care, because there were a number of points on that topic as well.
Yeah, the majority of plans we reviewed do offer lactation coverage and support. The supplemental prenatal care plan does not. And there have been a number of laws enacted in New Jersey, which are still in various implementation stages, that provide protections for individuals who are lactating and breastfeeding, particularly in the workplace, and the type of equipment that can be accessed and covered under health insurance. And so we'll provide some of those links and resources when we send out all of our post meeting materials. I know that there are other questions too that are coming in, and we are going to transition to stay on time, but we will have more opportunity to dialogue toward the end of our session here today. One thing that I do want to comment on is that this report really just looked at the coverage that was available via these health insurance markets, and we didn't go into understanding or gauging accessibility of care providers. So I know that there was a question, and this question has come up on a number of occasions, whether folks are able to access the care that they need, either obstetric gynecology care, midwifery care, birth center care, all of the above. And so that was not addressed in the report. However, we can certainly discuss if people are finding that there are gaps in care, we'll have opportunity to discuss toward the end of today. So we are going to transition. And so I'd like to invite our speakers who are on our panel to pop their video on, and we will begin spotlighting you. But as we transition to our panel, we're going to be talking today about how gaps are being addressed and what more is needed to address these challenges for care across the perinatal period. I'll be reading short bios of our presenters, and then we'll get into our questions. We'll have opportunity also for you all to ask questions during a brief Q&A period, but you're welcome to stick them in the chat as we go if you don't want to forget them. So first, I'd like to welcome Janice Rybicki, the Manager of Behavioral Health Implementation at Horizon Blue Cross Blue Shield of New Jersey. Janice is a licensed professional counselor who started her clinical career working in community mental health with a primary focus on individuals with serious mental illness. As the Manager of Behavioral Health Implementation at Horizon and Director of Strategic Partners and Product Innovation at NovaWell, she manages the strategic partnership and product team, which includes oversight of a unique virtual front door that allows direct access to care. We're so excited to have you here today, Janice. Thank you. Next, I'd like to introduce Dr. Patrick Fox, President of the New Jersey market at WellPoint, one of the managed care Medicaid MCOs in the state. Dr. Fox is responsible for all aspects of the health plan's operation within the state, ensuring its members receive access to innovative, high-quality healthcare and support services. He leads efforts to strengthen relationships in the community with state leaders, providers, and other key stakeholders. He has more than 25 years of experience in both public and private sectors, including Chief Medical Officer of the Colorado Department of Human Services and Acting Director of the Colorado Office of Behavioral Health. Most recently, Dr. Fox served as Elevance Health's Medicaid Plan Director in Colorado. He received his medical degree from Rutgers, New Jersey Medical School, and completed his postdoctoral training in psychiatry and forensic psychiatry at the Yale School of Medicine. Thanks for joining us today, Dr. Fox. Dr. Fox and Janice will be talking about behavioral health carve-in services here in New Jersey. I'd also like to welcome Yvette Pittman, the Assistant Director of the ALMA program at Family Health Initiatives. She holds a Bachelor's of Science degree in Public Administration from Virginia State University and a Master's of Arts from Human Services Administration from Lincoln University. With over 15 years of experience in human services, Yvette is passionate about serving others in her community. She's dedicated to building strong partnerships, advocating for maternal health, and making a positive impact on the lives of women and families. Welcome. Finally, I'd like to welcome two additional folks. Dr. Nicole McGrath Barnes is founder and CEO of the Kindersmile Foundation, established in 2007 to address oral health disparities after witnessing the devastating impact of preventable dental disease. Kindersmile Foundation's mission is to provide underserved children and families with access to comprehensive dental care and educate them about the importance of dental hygiene. A graduate of the University of Maryland and a fellow of the American College of Dentists, Dr. Nicole is a tireless advocate for oral health equity, recognized as a diversity, equity, and inclusion champion by the American Dental Association, and has been awarded the Access to Care Innovator Award in 2024. Dr. Nicole continues to lead transformative efforts to ensure every child has access to a dentist and the opportunity for a healthier future. Welcome, Dr. Nicole McGrath Barnes. And then last but not least, I'd like to welcome Dr. Michael Herman, who is the Chief Operating Officer at the Kindersmile Foundation, a nonprofit dedicated to improving access to oral health care. Since joining as a volunteer in 2009, she's advanced through roles as dental provider, grant writer, and dental home director, demonstrating an unwavering commitment to bridging oral health disparities. A graduate of NYU College of Dentistry, she's completed a residency in general practice, and in 2024, she co-produced the award-winning documentary Toothache, The Painful Truth About Oral Healthcare Inequity, which has won a number of awards. If you haven't had the chance to check out that video, I will put in a shameless plug. It is fascinating. She was inducted as a fellow of the American College of Dentists, and an honor received by only 3.5% of U.S. dentists. Thank you all so much for joining us today, and we'll jump right in because we have a lot to talk about. Janice, I'm going to turn things over to you. On January 1st, New Jersey Family Care moved administration, coordination, and reimbursement of outpatient behavioral health care to the managed care organizations, effectively called the carve-in. How has Horizon worked to create a robust network of mental health care providers, and how do you work with your pregnant and postpartum members to make sure they're screened and connected to healthcare services, mental health care services?
Thank you so much for having me here today. It's an honor to be here with all the panelists. So 2 questions, and I'll start with the first on building our behavioral health network. And there are really 2 elements that we work toward. And the first is, just access itself. When someone raises their hand and is ready and wants help, we need to make sure that we've got the providers in place to meet that demand. And, we've really focused on growing our network. So, since 2020, in terms of our commercial market, we have grown 143%. And then within Medicaid, we've grown 126%, right? So access is definitely key. But beyond that, the next really level down is looking at quality. Right? We want to make sure that we have the right people in our network, the right providers who are using evidence-based treatment, that are, giving measurement-based care, and so that our members are going to providers that are going to help them based on what condition they have, and that we're really seeing those improvements. So that's really the next step down that we've done. Last year in 2024, we brought on Mavita Health, who is a They work with members across the lifespan in terms of, parenting. So, people starting with fertility, starting to think about having a child, all the way up through postpartum care. So that is in terms of the clinical aspect, providing therapy and medication management. And we're in the process of bringing on another provider as well that will offer more of a preventative piece. So working with people who are pregnant, some preventative care as well as postpartum treatment as well. So really building out that robust network. We really have the philosophy that there is no wrong door. So you had asked about screening as well. So our digital front door that we have, that gives members access to a wide variety of maternal health resources, podcasts, videos. So you can go in there, get the information on your own. We also have a screening tool, an assessment tool in there that screens for depression, variety of conditions. And if someone does screen positive in there, we provide them with some in-network resources that we have. So helping crosswalk people into the right type of treatment, excuse me, based on what condition they're experiencing. We do have a specialty payment program as well. So part of it too is working with our providers, incentivizing, ensuring that providers are giving the screenings, and then also working so we can explain to our providers what are the resources that we have at Horizon, and being there to help connect if there are some maternal or some mental health issues that arise, making sure there is awareness of what we have to offer. So the last thing that I want to talk about too, I know you had talked earlier when you shared some member stories about the doula program. We do have coverage for Medicaid. So we do offer and have coverage for doulas for our Medicaid population as well, which we know can also be key in getting helping people navigate to those appointments, making sure that they are getting screened when appropriate.
Thank you so much.
Yes.
Thank you, Janice. I appreciate it. Dr. Fox, I'd love to turn to you next. How has this changed to managed care organizations covering mental health care been able to better support the mental health needs of pregnant and postpartum people?
Thanks, Kate. This is an exciting development in time in the New Jersey Family Care Program. It's going to benefit all New Jersey family care members, not just those who are pregnant or postpartum. But we believe that highly integrated and well-managed care can help break down silos, address system fragmentation that's been so prevalent, because behavioral health and medical health have essentially evolved through different systems in the United States. And so integration is going to be key in order to meet members where they are and address all of their needs. The statistics with respect to pregnant individuals are sobering and require attention. 1 in 5 individuals who is pregnant will experience a mental health condition during the peripartum period. Of those who do experience a mental health condition, about 75% are either undiagnosed or untreated, and treatments are available. We know that untreated mental health issues can have a detrimental impact on the pregnant woman, as well as the growth and development of the child. And estimates say that the cost annually from untreated peripartum mental health approach is about $14 billion a year. So we think the state of New Jersey took the right steps in integrating behavioral health into the managed care benefit. We're going to be able to track through the pregnancy risk assessment individuals who are experiencing mental health crisis or mental health issues during their pregnancy, and direct them to appropriate providers who can provide timely care.
Thank you. That's very interesting, and those statistics are certainly sobering, and hopefully this will have a chance to impact them positively. For both Dr. Fox and Janice, I wonder if you could tell us a little bit more about the challenges you've anticipated as you approach January 1st and this this change in behavioral health care coverage. Specifically, are there critical services support that you focused on? And also, has technology played a role in how you've been planning for this care?
Janice, would you like to go first, or would you like me to go first?
Please do.
Okay. Um, so this is more than just a lift and shift, right? So the outpatient behavioral health benefit has been available for some time, but transitioning responsibility from the state to the managed care organizations has been a huge task. There are logistical challenges. For us, first and foremost, it's ensuring that members get services and providers get paid. We've done extensive readiness reviews, worked collaboratively. It's been a collective effort. All of the managed care organizations, our state partners, the New Jersey Association of Mental Health and Addiction Agencies have all been, and the providers that they represent have all been integral in bringing this day to fruition. We've still encountered some bumps in the road. We still have a lot more work to do. The integration is in its infancy, and as we work through those issues, our focus is on expanding our provider networks, ensuring that we're connecting primary care and obstetrics providers with behavioral health resources, so that when they do identify a member with a mental health need, that they know where to direct that member, and so that member can then receive adequate, competent, and timely care.
Great, thanks. And I'll kind of share next based on that same question too. So to reiterate what Dr. Fox just said, not an easy lift. It's been a lot of work to bring in the mental health network, make sure that we're building it correctly, really focusing on the access piece first. And, we're going to continue to look at quality and how can we make sure that we've got the quality of providers as well, because I think that is completely vital as you build your behavioral health network. In terms of, technology, so early intervention too is going to be key early. And with that, really being able to detect and know when a member is pregnant pretty early, making sure that if a member goes to the emergency department, does not yet have an OBGYN, that they're getting crosswalked into care. And conversely, if a mental health issue does arise, that our providers are well equipped and again knows what are all those resources, what are those supports, from the health plan in the community, how can we help connect members. We want to make sure that those screenings are being completed, and that again equipping providers with knowing, if you have a positive score, what do I do next, and making sure that it's as seamless as possible to help connect the member quickly into care.
Thank you both.
And I would actually add, if I may, Kate, to that healthcare is evolving. Technology is really taking a more central role as an empowering tool. It doesn't replace healthcare providers, but really is a tool that providers and patients can use to better educate themselves, to be more to play a more central role in driving healthcare journey. So app-based resources, live chat functions, and other tools available within healthcare apps can really help patients and providers to better address healthcare issues as they arise.
Thank you for that. Thank you both. As we transition, I want to put one more question out there for you. How have you been communicating with members? And a surprise bonus question, we've got about 117 folks with us today. Are there ways that we all can help you communicate this change and coverage better?
We've been using every tool available in order to get the word out, telephonically, through provider and member facing events. We participate in Nurture New Jersey community events led by the First Lady Tammy Murphy across the state, and our annual summit for providers and members was specifically focused on behavioral health integration and what was changing and the ways in which the benefit was going to be expanding. We welcome assistance from all to ensure that that every New Jerseyan who qualifies for New Jersey Family Care is aware of the behavioral health benefit, particularly for pregnant individuals, because it's such a critical time because of the high rates of mental health conditions that arise during the pregnant and peripartum period. It's crucial that there's early identification through risk screening tools, connection to care, and then monitoring of effect to ensure that that condition's being effectively managed and symptoms are being mitigated.
Yeah, and to that point, I don't think we can over communicate anything. Sometimes it might take 5 times to really hear something, or you might not connect to hearing it until you need it the most. And I think, any support, any channel of communication, we cannot over communicate that there is the behavioral health benefit, and including what are all those resources and support as well. I think there's just so much that is out there to offer, to crosswalk, to help people, and continuing to drive awareness and really normalizing reaching out for help, normalizing seeking behavioral health treatment when it's needed.
I'll add to that as well, but Janice's last comment is so important that what we know for a lot of individuals who post delivery don't really recognize that they're depressed or dismiss it because they say, well, this is a period that should be such a magical time for me. I'm supposed to be upbeat about the fact that I've just delivered a child, yet I don't feel that. And so I don't really feel comfortable coming forward and expressing to people when they basically are congratulating me for my recent delivery that I'm actually struggling. And so it's really important that we get the message out that with a high rate of mental health conditions that occur during pregnancy and in the period following pregnancy, that it's not uncommon, and that if you're having any issues, anxiety, depression, certainly psychosis, though much more rare, let people know. And if you know someone who's pregnant or recently delivered, ask them, keep an eye out for softer, more subtle signs that person may be experiencing mental health symptoms or could just use additional support in some way, lactation support, education about how to care for a newborn, how to adjust to erratic sleep patterns in a way that causes minimal disruption.
Yeah, it's so essential that we destigmatize mental health and talking about mental health at any phase of life. And so Janice and Dr. Fox, thank you so much for offering us insight into how you are being supportive in regard to behavioral health. That was actually also an excellent transition to our next presenter on our panel, Yvette Pittman, who runs the ALMA program. And Yvette, I'd welcome you to share with us a little bit more about the ALMA program. How is it filling critical gaps in perinatal mental health for vulnerable populations?
Thank you. Thank you. First, thank you for giving me an opportunity to be here and amongst this awesome panel. And definitely what Dr. Fox said is exactly what ALMA does. We are here to service moms, new and expectant mothers, or women who have just recently given birth, to provide them with peer-to-peer mentoring. That is what our program is about. It's an evidence-based peer mentoring program that was developed by a group of mental health providers, researchers, community members, and moms through the Crown Institute out of University of Colorado. Our program provides support to moms who may be experiencing depression, anxiety, or stress, but really it's for any mom, anyone that is currently pregnant, expecting, or may have recently had a child within the last 14 months. They qualify for the AMA program. AMA recently expanded our program. We are now statewide as of July 1st, 2024. So we're excited about that. We have partnered with the Northern Central Consortium, and we are now training our 4th cohort of AMA peer mentors. Our peer mentors are moms who have lived experience. That's one of the main qualifications to be a part of this as a peer mentor. And then they're trained to be AMA peer mentors. They're trained on the AMA model, which is based off of behavior activation. They also have licensed mental health supervisors who were trained in AMA, and they work closely with the peer mentors as they're working with the moms to provide additional support when needed. The way our program works is moms are referred to our program through either Connect NJ, because we are hub partners, PRA Connect, and they can also self-refer or be referred by their providers to our landing page, which I'm going to actually drop that information in the chat. That's the link for our website where you can get more information about the AMA program, as well as if you would like to refer moms or just provide mom with the information they can refer themselves. And then I have my email address if you're interested in having brochures printed and mailed out to your offices so that you can have to share with your programs as well. But the peer mentors meet with the moms once a week for 1 hour. It can be in person or it can be virtual. So we meet moms where they are. If mom is in unstable living situations and they prefer to kind of meet virtually, we're able to do that. We're understanding that we have some moms who may not have the ability to have access to Wi-Fi or whatever. So sometimes the peer mentors will meet with the moms by phone, or they can meet with them at some of their local appointments at social services offices, family success centers, wherever is possible. We try to connect with the moms. Those sessions take place for about 6 to 8 weeks. And sometimes we are able to extend it to 10 weeks if we feel mom needs additional support or there's been just a lapse in meetings due to conflict of schedules and things like that. But from my basically we're able to provide the resource to the moms. We also have incentives where we're able to provide moms with e-gift cards as they continue to work with their peer mentors. A part of our intake process, we do a health evaluation assessment, which consists of the PHQ-9 assessment as well as the GAD assessments to see exactly where a mom is in regards to her level of depression, anxiety. And so as they meet with the peer mentors, that's also another way how we're able to gauge how successful they are progressing through the program. And if there's any concerns, myself and a licensed mental health supervisor are able to review the scores and assessments and kind of reach out and connect with the peer mentor and the mom to provide additional support or services. We do have a safety protocol in place for any emergency crisis situations where we're able to have someone available for the peer mentor and the mom to connect with to get them to additional support that they need. We often encourage moms as they're progressing through the session with their peer mentor to connect with other support systems. So we're looking actually to start our own AMA virtual mom support group because we know the importance of the connection relationships and what better opportunity would be for them to connect with moms who's going through the program who are familiar with the same skills and tools that they learned and kind of have like a refresher and things like that. Our programs also being evaluated by the College of New Jersey. So they follow our moms up to a year just to see how they're progressing, how they're doing, if they're still utilizing the skills and services that were provided to them while they were working with the peer mentor. The skills and services that were provided to them.
Wow. Thank you so much, Yvette. That was such a comprehensive review of the ALMA program and amazing that it has scaled already across the state. Can you share one or two challenges you've seen and strategies that have been effective to ensuring that you're able to reach moms and that they get the care and support that they need?
Yeah, some of the challenges that we experience is really getting moms connected with moms and getting them fully enrolled into the program. We've been able to touch about 200 or more moms, but only about 22% have fully enrolled into the program. And so we're being creative in ways to really keep the engagement going, establishing a stronger relational rapport. We understand a lot of moms are facing challenges with homelessness, limited financial resource. So them working on themselves is not really a main priority for them. But we try to help them understand that the skills and the tools that they learn and obtain while working with the peer mentor will help them as they're navigating these different challenges of life.
Thank you so much. Now, you've been successful in a pretty short amount of time scaling ALMA statewide. As we close up with you, do you have any words of advice or specific policy changes or funding strategies that you think would accelerate processes like this for other folks who are trying to scale programs?
I think it's important is the collaboration and connect with other programs. We know no program is cookie cutter, so we have really been focused on connecting with other community organizations, providers, to be able to provide a wraparound service and support to the moms, to help them be successful.
Well, thank you so much. We wish you all the best as you continue to scale and grow this program in the state, and it impacts so many lives.
Okay.
A moment of transition away from mental health and to dental health. And we're excited to have Dr. Nicole McGrath Barnes and Dr. Michelle Herman with us from the KinderSmile Foundation. I'd love for you both to describe a little bit more about the KinderSmile Foundation's care and perinatal health and wellness program and how it connects to healthy outcomes.
Well, first of all, thank you so much to the New Jersey Healthcare Quality Institute for spotlighting dental health and oral health care this whole year, actually, and everything that we're doing in your partnership. So, KinderSmile Foundation's perinatal health and wellness program empowers uninsured and underinsured mothers with education and dental care to link dental and medical integration. Because dental care is so important to the overall health. So let me go back a little bit. So uninsured moms who are uninsured due to documentation and not eligible to get Medicaid insurance from the state are eligible or qualified to get free dental care from our program if they complete the educational session. So the educational session teaches them about the oral health of themselves and their babies in order to also reduce early childhood caries that we see a lot of times in babies. And importantly, we link mothers and all of their children to a permanent dental home so that they can get always continuity of care and reduce emergency care visits to the hospital for dental disease. You want to jump in? I'll do a little more. So moms, pregnant people have a 60 to 75% chance of having gingivitis. Gingivitis is inflammation of the gums and a precursor to periodontal disease, which periodontal disease is when gingivitis progresses a little bit more into further into the gums and into the bone. And periodontal disease causes makes moms 7 times more likely to have premature births and low birth weight children. So oral health is extremely important while pregnant and has been shown to be safe, effective, and completely recommended. And a lot of times we find that providers or medical providers still don't recommend oral health while pregnant. So aside from providing educational sessions for the moms, we also now provide educational sessions to maternal health workers, doulas, midwives, OB-GYNs, in order for them to also include oral health in their education for their patients.
Dr. Nicole, you're on mute still. Oh, there you go.
Sorry about that. Good afternoon, and thank you all. This is so exciting. And the reason why it's so exciting is because we're having a discussion about oral health. Long time coming. And so I just want to thank you, Kate, Linda, MAP, Quality Institute, all the panelists. Thank you so very much. And just like what Dr. Herman stated, oral health, the gateway to total health. And it becomes this vicious cycle. And I've been taking notes from the other panelists as well, is that you have maternal health, which is pre and post, which includes mother and child. You have the mental health, you have the oral health, you have the physical health. And so important that we talk about the importance of oral health and how it directly affects the child, but most importantly, the mothers are the matriarch. They need to be empowered and educated as well so they can continue this legacy of healthy mouths. So I just wanted to piggyback on what Dr. Herman said and how it's so crucially important that we have this discussion amongst our community partners and stakeholders too about the importance of oral health.
Thank you so much. More staggering statistics really about the link between oral health and overall health. And we appreciate you sharing that and the incredible need for dental health care. I'd love to ask you what policy or system changes would most help programs like the perinatal health and wellness programs that KinderSmile runs, so that more providers and pregnant people understand the role of oral health and perinatal care and ensure that no families fall through the cracks.
Great. So currently, I am not aware of any oral health policy in the state of New Jersey that's inclusive of perinatal health. Other than what you mentioned earlier, which your presentation prior to the panel discussion was so replete and informative, the New Jersey Supplemental Prenatal and Contraceptive Program is run by the state of New Jersey Family Care. It's helpful, but very, very limited. Helpful and because it talks about the planning series to the women who are not qualified for NJ family care, but extremely limited. It doesn't include oral health. And oral health, like I stated before, is the gateway to total health. And in addition to that, according to the website, it doesn't even include hospital visits or labor and delivery. And what happens postpartum? We all, Dr. Fox and Janice and Yvette, we all talked about what happens with the mental health component, right? We have to also tie oral health into that as well, because we have a lot of mothers who don't have access to oral health care. They're in pain, and that can lead to mental health. So we have to do better in terms of oral health and implementing that with maternal health, physical health, mental health. It's just as important. So we would love to see an inclusion of those undocumented mothers' oral health, part of that New Jersey expansion to include oral health. The medical dental integration is extremely important. We also worked very closely with the Quality Health Institute to develop the MOM bill, maternal oral medical bill, and that it replicates our perinatal health and wellness program to ensure undocumented mothers have access to the education as well as dental services during their pregnancy and definitely after. Very, very crucial that we implement oral health and make it a discussion with our doulas and our midwives, even during the family planning sessions. Insert a question or two about when was the last time you saw a dentist? Have you ever been to the dentist? Do you have access to a dentist? Just these questions can stir up a discussion to help them with their family planning.
Thank you so much for that, and for the need to continue to grow and make access available, as well as really understanding people's history with the dentist. I think that's so essential as part of our health histories that we collect from those that we're working with. I would like to welcome any of our participants now to engage in questions and answers with the panel. I've certainly dominated the stage in asking questions, and I know there's been some dialogue in our chat box, but I would welcome folks to raise their hand and ask questions of the panelists. I'm happy to call on folks as they raise their hand. You're also welcome to drop a question into the chat box. I'm just going to summarize a little bit about what I've been seeing in the chat, and then I've got a bit of a question for you, Yvette, which I know you've been answering. Someone who's been participating has recommended that doulas be part of the ALMA model, and I'm wondering if you can share a little bit more how doulas are currently part of the model, and then a little bit about the peer mentors and their background.
Sure, no problem. So we currently have two peer mentors who are doulas. And there's a training program going on for new doulas, and I've been contacted to see if we will be open to having at least three of the doulas offer free services to our moms. So we're looking and excited about the opportunity to collaborate. But a lot of our peer mentors have prior background experience in doula services or some type of community health worker position. Part of their training as our peer mentors, they also, if they do not already have a CHW, they are certified as community health workers that are as well.
Thank you. That's very helpful to know. And certainly, if you have openings for peer mentors in the future, we're happy to help you get the word out.
Thank you.
Thanks.
At this time, since we recently expanded, we are fully staffed in regards to peer mentors, but hopefully in the near future, as we continue to grow, especially with the expansion, we will be looking to bring on board more peer mentors. And so I'll definitely make sure we get the information out there.
Thank you. This question is for Dr. Fox and Janice, and a little bit also for Yvette. I'm wondering if there have been efforts in regard to behavioral and mental health that do connect managed care coverage with some of these community programs, or are there ways that you could see opportunity to strengthen those connections?
I think there's always opportunity to strengthen the connections. As I mentioned in the beginning, the mental health care delivery system in this country was established separate and apart from the medical system, right? In the mid-19th century, we had the asylum system. So individuals were in state mental health hospitals. We had the Community Mental Health Center Act in the 1960s that for the first time created at a federal level community mental health centers. It coincided about the same time that Centers for Medicare and Medicaid Services came online, that Medicare and Medicaid as benefits came online. But we've been working now for the better part of 60 years to try and figure out how do we integrate. And I think when we think about integrating care, for me, the way to think about it is what's most important is to put the patient at the center for oral health, mental health, addiction, social supports, and physical health, and then figure out the way in which systems are optimally designed to meet the needs of that patient. And that's going to look different in different communities. It's going to look different in different practices. And so in some instances, it could be fully integrated. Think about like FQHCs can often have everyone under one roof. In others, they can be co-located. And in others, still, it's if an OBGYN has formed a relationship with behavioral health providers, and they have that familiarity, we've sort of broken that relational silo, then when an issue comes up during a visit during the pregnancy where mental health is an issue, that OBGYN knows who to call and have an appointment. Or if the dental issue arises during an OB visit, they know who the dentist is that's accepting referrals. So for me, it's as much about forming those relationships than it is necessarily dictating what the systems of care should look like from an administrative or structural standpoint. It's whatever gets the job done based on the realities of the part of the state in which you live and the way in which practices are set up. I mean, with the ability to share information bidirectionally between healthcare providers through health information exchanges, it's less critical that care be delivered in a fully integrated setting under one administrative structure. More importantly is that information is communicated about needs, and that follow through then occurs with feedback loops, so that if I have a person with a critical dental issue and I refer them to Dr. Herman provides the treatment, that I receive feedback back about how that treatment went, and if there are any aftercare instructions, that I know what they are, so that when that patient then visits with me, I can then have further discussions about, want to talk about your mental health right now, want to talk about your pregnancy and how that's going. But I heard from Dr. Herman that that procedure went well, but have you been taking your antibiotics post-operatively? Because it's really important that you do that. Like that really for me is what an integrated system looks like, more than, again, just an org chart.
I definitely want to piggyback on what you're saying, Dr. Fox. You know, the complete value of integrated care, right? And I think making sure that everyone is asking all the questions, right? So asking about social determinants of health, right? Assessing, you know, again, someone might not be able or ready to address their behavioral health if they're hungry and have food insecurity, right? So making sure that we're asking all the right questions and from a holistic approach. So, you know, if I were an OBGYN, also remembering you mentioned touching on oral health. Let's make sure we're asking about oral health, asking about behavioral health, asking about social determinants of health, and connecting to those programs. And conversely, I can't reinforce more what Dr. Fox was saying, that we're all collaborating and sharing information so that it can continue to be reinforced from all angles, because that really is the best way to kind of wrap around and support an individual. You're not just going here for your behavioral health. You're not just going here for your OBGYN, your prenatal care, right? We are all working together and really trying to walk you through this whole process.
Thank you. I'm going to stick with the two of you for a minute with some follow-up questions that have come into the chat box. I'm wondering if you could share any current work that you're doing directly with providers to make sure that they are aware of the best evidence care needs through screening and access for oral health and mental health. I know there are lots of different pathways. No door is the wrong way, but are there particular engagement strategies that you're trying?
Yeah, so I can go first if that's all right. So we have been working on internally, really thinking about integration and how we can really support our external providers. So primary care, OBGYNs. So really spent the last year working on a strategy, pulling together tools and resources and support. We're about to launch that. And really the message is, you know, here's the value of integration. Here's why it's important, right? Here's information on the collaborative care model, something that, you know, we reimburse. I don't think that everyone really knows that that health insurers do have coverage for that, right? But also importantly, sharing information about what are the tools and resources. And then, you know, if a member were to have depression, what are the evidence-based treatments? So really providing a pretty comprehensive list of all this information, you know, not to just to really help provide that additional support. And then also helping our providers know internally what Horizon has, how we might help support them, but also, you know, more importantly, just making sure that we're asking the questions and getting everyone to the right level of care and support, wherever that may be.
Hosting provider education events to make providers aware. I will say that presently the primary focus is on how to submit a claim and what the requirements are for, because of the rollout of the benefit. But certainly over time, the focus is going to shift away from the early phase of the integration and of the behavioral health integration into the managed care system, and more into, to Janice's point, providing comprehensive, whole person-centered care.
Thank you both. There have been a few questions in the chat, and I'll open this up to everyone. I'm going to try to tie them together a little bit, but it's been shared on a few occasions that the need to have, you know, comfortability or rapport with the individual when you're asking about such sensitive topics, inclusive of mental health and or oral health care. Are there ways or best strategies that you all have seen in order to support providers, peer specialists, and others so that families feel comfortable expressing their needs, particularly if they're concerned about involvement of child protective services or, escalating supports? So happy to have any of you jump in.
I think piggybacking off of Dr. Fox, when you put the mother first and in the center, and she feels that she's priority, you disarm her. If you just start out, how are you doing? How is your day? A lot of times our Black and brown mothers going to facilities, and the first thing that they're asked is, what insurance do you have? What month are you in? There's no human connection. And so therefore, there's a wall. They become armed. And how do you find out that they're not doing well mentally or they're having food insecurity? So I really say, and this is part of the Kindersmile Foundation culture, is that patient is in the center. That patient is a human being and not a number to bill Medicaid or managed care. So always remember that. And that's when you disarm them. And when you say, how are you doing? They can answer, well, I'm not doing so well. And then you proceed with the conversation and offer collaborative efforts to help them in whatever department, whether that's mental health, physical health, and so forth and so on. So I would say putting the mothers at the forefront and in the center all the time, so they understand that they're being heard.
I would add that check your own pulse. So if you want to put patients at ease, you need to be at ease. And so if you're not comfortable asking questions about a person's depression or thoughts of hurting themselves or their newborn child, that discomfort is going to come out non-verbally. And so check your, check yourself. The more you ask questions with an interest in understanding and maintaining safety, and to the extent that you can, if it's coming from the right place, if you're leading with your heart, that'll be sensed as well, and that you're genuinely concerned about this person and their well-being. And again, if an expectant mother doesn't know that 1 in 5 of her peers are likely to experience a mental health challenge during this period, that individual needs to know that, and that very often it goes untreated, and that's avoidable. Like it's a preventable morbidity, and so we have to do more to educate people to say it's okay to ask for help. I mean, I didn't get a manual like when I had kids, right? We sort of go through it. No one is. And so helping people to understand and educating and supporting them and supporting their direct supports. So I know that Dr. McGrath said, like, put the mom at the center. While that's important, there are others that orbit much closer to that person, have a much more profound influence, and they may be nervous or unclear or unsure of what to say or how to approach. And so helping not just if you will, the patient, but their immediate support system about, it's not uncommon. You may notice that your loved one may experience difficulty, mood swings, difficulty sleeping, crying spells. These are signs, these can be signs that there may be more going on, and we want to try and help them.
If I could just real quickly, Kate, too, is if a mother comes into one of our dental homes and she's accompanied by her husband or other family members, it's also important to bring those family members in the operatory and just like what Dr. Fox, find out how everyone in your familial environment is doing, and that will sort of disarm them as well. But it's just human care. Why are we in the profession that we're in? Why do we serve the communities that we serve? Always remember why we're doing things. And I think that will, once you lead that way, I think it makes for a much comfortable environment and positive outcome.
I just want to add, I definitely agree. One thing that we do as part of our intake process is that we do ask questions of the moms, like, their mental health, their substance use history, any barriers they may have. And so once they come through the second part of the intake process with me, I'm really going over those things, on which I'm also utilizing that information to develop a mom fact sheet for my peer mentors. So that way, once they prepare to meet with the mom, they already know their background history, what's going on, what mom's dealing with. And as I'm meeting with mom during that initial intake, I'm then connecting mom with resource at the same time. If mom's having issues with housing or food or whatever, she's unemployed, she's looking for something, I'm then sending information and resources to her as I'm connecting and preparing her to be matched with a peer mentor. So it allows us the opportunity to kind of address some of those issues that they're dealing with, and just be very transparent, open. And then as they connect with their peer mentors, they're able to be vulnerable because they already know why they're there and what it is, what their needs are.
I just wanted to add one thing as well, if I may. So in terms of, asking the intake questions, assessment questions, I don't know about you all, sometimes I get anxious about going to the doctor, right? And so I think we're just quick to say yes, no, right? But really providing some context too about why you're asking some of these questions. And, I think instead of going right into them, and I'm not saying you're doing that, Yvette, I'm talking about for all of us, right? To make sure that we're giving some context and why we're asking some of the questions too can really help alleviate that anxiety and add that human piece again to, and put some context around those questions that we're asking and why we care about the response.
Thank you all so much for your insightful experience and advice today. I know we've covered a lot of information, and we still have some time left together today. So our panelists, I want to give you a big round of applause, virtual round of applause. You can pretend you're hearing the roaring crowd. Thank you so much for your time today. We're going to transition back to Linda, who's going to be leading us in a group discussion, but our panelists will remain with us today, and I invite you to continue to interact throughout the group discussion. I know that we didn't get to every question in the chat, and I'm hoping we're able in some way to address them during our group discussion, as I think a lot of folks will be able to chime in and provide some interesting answers and responses. So Linda, I'm going to turn it back over to you and to our panelists. Thank you all so much.
Yeah, thank you. Thank you so much, Kate, and all of our panelists. It was great conversation about the existing process and some of the gaps and ways that you all are addressing those gaps. At this time, I would love to hear from those of you in our audience about, in addition to the gaps that we just discussed, if there are other gaps that you're seeing. Some of them might have been mentioned by Kate when she was going over our newest report. But if there's other gaps that you are seeing in your provision of care or services to pregnant people, that you would like to come off mute and highlight. And also, if I'd love for anyone on here, if you have examples of how you are filling those gaps, either bright spots or bright ideas that you can share with others, now is the time to really share those ideas with others who are here listening and may be facing similar challenges. So I will pause for a moment of awkward silence so those bright spots can appear.
Can I just say something for a
Yeah.
second? So I'll say that the perinatal health and wellness program is fully grant supported. And because it's fully grant supported, we have the ability and the funds to provide the educational session for the moms. So they participate in a 2 to 3 hour educational session. But providers who are solely relying on Medicaid for their reimbursements are probably not going to have the time to spend on the education for the moms. So back to Nai's question, she added a question in the chat, how do we get providers to be able to give us the 15-minute time? If it's not reimbursed for them and they don't have grant support, they might not actually spend that time and money and resources for the extra education for the patients.
Thank you for that. So I think that goes to some of the commentary in the chat that while as you all so ably said, while comprehensive care and integrated care is really the gold standard, too often today, some of our payment systems, unfortunately, are not set up in that way. The incentives aren't aligned to enable that delivery and spending more time. So it's just something to think about as we think about model design moving forward. How can we change that, whether it's at a primary care location or a dental medical home, or an integrated clinic with both everything, dental, medical, and mental health, allowing for a comprehensive visit of a global payment or separate, being able to bill various codes all at the same time. If we're asking providers to spend a lot more time with their patients, which we are, how are we supporting that in a model that makes sense for them financially as well? One of the questions that I had while I'm waiting for others to give examples, Dr. Fox and I think Janice as well mentioned the use of technology, and that there's so many apps out there now, particularly around mental health, both for patients and sometimes it's interesting, the studies out there, patients actually oftentimes feel more comfortable talking to a chat bot than another human being because of the unfortunate stigma. I'm wondering if either of your plans are using some of those technologies or looking into using some of those technologies, or if you're aware of other plans or organizations that are, maybe you could share a little bit more about that, because again, going back to mental health and addressing some of both the access issues as well as the stigma, I do think that's a promising area.
We have live chat functionality within our Sydney Health app. Within other markets in which we're present, certainly in Colorado, when I was there, we used Pix Health, which is an app that helps to address loneliness, and it showed some promise. We haven't made a decision as to whether to incorporate that here. But we do have live chat functionality so that you can communicate with an individual right within our app, rather than chat.
A couple of other examples were dropped in the chat too, Linda. Dr. Lamborn, if you want to come off mute and tell us more about it, says they use Woebot in combination with their PMAD program. And then also Karen Barnett shared that chatbots enable individuals to remain anonymous and don't always have the same bias as an individual human provider.
Hi, Kate, it's Nicole. Yes, we use Woebot. Our Woebot program, they do sign up for it. It isn't anonymous, although it's anonymous in the chat. We know they're participating in the program, but we don't see their chat or what they say back to the chatbot. So I guess in that way it's anonymous, but we have not rolled it out to use without simultaneous counseling services, because we just don't want people to feel abandoned or alone. So we make sure that they're already kind of hooked into our perinatal mood and anxiety disorder program, and then offered the additional support of the Wobot. So it's an interactive app. The nice thing about the app is it keeps reaching out to the patient. So if they haven't heard from the patient in a couple of days, it prompts them with, how are you doing today? And, how's the baby? Different things that they've gathered information on the patient when they first sign up for it. So we've had really good results using it in the general population. We've just started using it in our maternal child health population. And so far it's been promising, and we're happy to have that in addition to the counseling services. So we're excited about that.
Thank you, Dr. Lamborn, and thank you, Dr. Fox, as well. Helen Hannigan, I see your hand up.
Thanks, Linda. Hi, good afternoon, everyone. I just wanted to mention a few things, and I know many of my partners are on the call with me, so hopefully I'll represent some of the technology that we're trying to use through family health initiatives, and we're the organization that supports the perinatal risk assessment screening for Medicaid. That is required for Medicaid members. And through that project, we've worked with our partners at the Camden Coalition to develop a strategy that identifies when a member does go to the emergency room and doesn't yet have prenatal care established, that using the perinatal risk assessment as that kind of identifier, and then connecting those individuals to Connecting New Jersey, so that the outreach is done through Connecting New Jersey to provide support, whether the individual needs care, prenatal care, or other kinds of linkages. And we're looking at other models and other needs that are identified during an emergency room visit, even for patients who do have prenatal care, to make sure that same outreach is provided, and that evidence-based programs like our MRAP program, ALMA, and other available services are linked to patients. Really importantly, and I know one of the things that we've heard from many of you on the call is around, how does the patient have an awareness? How does that pregnant person know this is going to happen? And so we did launch 2 years back, again, through a collaborative effort, Your Health, Your Story, which is a patient portal that introduces the patient to the idea that they've been screened and they may have been referred for services. And we have over 5,000 patients in our system that have connected with that, and that's plan agnostic. So just having had the perinatal risk assessment completed, that a text message is sent to the individual who was screened at their provider site, and they get information about that, including linkages. So I'm hearing some great additional opportunities, reaching out to our teams around things that we can do, but making sure, one of the areas I know is so important to everyone on in this dialogue is, how are we connecting these things, right? Not creating separate systems, and integrating and pushing our communities together through technology. And I'm seeing in the chat, and couldn't agree more, it's really about the individuals who will do the outreach and have that connection, really finding the people who may have an issue identified in a technology space. So we know that's really where the magic happens. And we've seen incredible results in terms of just that emergency department linkage, where the folks who are connected with have a really high uptake, over 50% in some cases, of interest in having additional services, and the need to support our teams to be ready, because oftentimes those are individuals experiencing perinatal loss or needing things beyond what folks who are in the middle of prenatal care connected to services might need. So it's been a really important project, and really highlights many of the things that we've learned through the MAP project and the other work that we've done together to really kind of activate on the ideas that come forward. So just wanted to be sure to share that.
Oh, thank you, Helen, for all of those references and background. If there are particular services or documents that you want us to share out with this group, you can either put them in the chat, or we're happy to send them as a follow-up as well. But thank you for all of those programs. Wendy, I see your hand is up.
Yeah, thanks, Linda, and thanks, Kate. This has been so great. I'm actually feeling really heartened by this conversation. The kickoff, of course, was a report about gaps and needs, but I feel like obviously in the report itself, but also through this conversation, we're coming up with a lot of really actionable solutions and ideas as well. And so what I'm thinking about and curious really for this whole group is how we continue to take conversations like this, which it's great because it's sort of multi-stakeholder, and use these ideas for change and better policies and programs with the payers, the providers, the patients, the organizations all here today to really start advocating for specific policies and changes given the opportunity with candidates kicking off already in our state for governor. So, how do we kind of take the ideas here? And again, I would love in this multi-stakeholder way, thinking about a shared platform for moving these solutions forward.
Well said. Very good question. I don't know if I mean you're you're on overtime, but I don't know if any of our panelists want to take that one on. uh, I'll take a stab at it then, and if you guys formulate your ideas. I know at the Quality Institute, we are definitely thinking about the upcoming election and really what our policy priorities are, and those that our members have certainly expressed to us, as well as our board. And I laid some of our priorities for the year out as well, but comprehensive health, particularly comprehensive primary care, and I would include mental health and oral health under that hat of comprehensive primary care, most definitely. Continuing with the importance of maternal infant health, are all on our top priority list. So we will be expressing those priorities in a bipartisan way to all the candidates, and would welcome anyone's thoughts who's participating in MAP or engaging with us otherwise. So it's an open door to sharing your thoughts with us. Any other bright spots that anybody wants to share at this time? And I will say we do have a lot of state government employees on the line, and we certainly appreciate all the great work that they've done over the last 7+ years on maternal infant health and making it a priority topic, and appreciate your partnership and funding of a lot of this great work that folks have been talking about today. I want to make sure that we're recognizing that a lot of this funding came from state as well as federal grants and private foundations as well, such as the ones that supported this work. But really having that all hands on deck focus has made this happen, and we greatly appreciate it. I'm not staring at you, Brandy, but I am recognizing you.
Hi, Linda. Thanks for the call out. I like to keep it low key. Hi, everyone. Thank you for being able to. What's going on here? Sorry, I don't know what's going on here. This has been really, helpful, and it's been a great discussion. And hello to some of my partners I see. Since Linda put me on blast, I'll do a plug for Family Connects NJ, which is the state's universal home visitation program. It's currently live in Cumberland, Gloucester, Essex, Mercer, Middlesex, Bergen, Hudson, Ocean, Sussex, Somerset, and Passaic. That's a mouthful. You can, anyone can access those services directly through our website. We did go live with self-scheduling in some. Thank you, Dr. Shaw. The website is in the chat, and you can visit there and share broadly. It's a great program. It's doing so many great things. There's so many great stories. Hello, Tony. There's so many great stories that we see and hear from the nurses. They're doing great work out in the community. They're really changing the trajectory and really identifying gaps in care, helping to make those connections. So, just want to highlight that program. And thank you for everyone that's working so diligently in this space to really support birthing people and keep our families safe. So thank you.
Thank you. Thank you for that program and the work you're putting into it to develop it. So As we wrap up, I guess I will also put out a plug for the work that we're doing with all of the birthing hospitals in the state, as well as many of the midwives and OBGYN practices across the state called Team with an M Birth, whose principles are really 100% aligned with the comments that were made today about centering the patient, focusing on what their priorities and needs are as they go through their labor and delivery. So if you're not familiar with Team Birth, we'll also share some work on that. We are in the process of bringing Team Birth, which is a shared decision-making practice, to every labor and delivery hospital in the state. We've now trained and coached 19 separate birthing sites, 2 birthing centers, and 17 hospitals. And over the course of the next couple of years, we'll be doing that at all of the hospitals. I know we have a lot of the hospitals that have participated in Team Birth on the call today, and we appreciate their focus on this program, which really is having results of patients telling us that they felt much more autonomy and engaged in the birthing process, and so we're thrilled to hear that, of course. To wrap up, I wanted to share with all of you that our next MAP session is going to be on April 2nd, same time from 12 to 2. We will at that time be spotlighting the topic of preeclampsia and postpartum care, a very important topic for maternal health and avoiding maternal morbidity and mortality. So stay tuned for that. I saw many of you that were going to be reaching out to be speakers on that topic, so we're thrilled that you're here with us today. And look for all of the follow-up materials. And again, thank you to our funders of the patient journey. I encourage you to take a look at it, particularly if you'd like to take a deep dive on insurance laws and regulations and how these benefits are structured and under what authority. And I also would like to thank our panelists for really lending us your time and your expertise and helping us educate all of the participants. And thank you to our participants for your attention and engagement. This is work that we really are all doing together. We appreciate your partnership, and have a wonderful rest of your day. Thank you.